Hello and welcome to Healthline 3. I'm Terry Simmons. Today we're talking with Dr. Jim Burke with Willis Knighton Advanced Laparoscopic and Robotic Surgery. We're talking about the benefits of robotic surgery, and we'll be taking your calls throughout the show. As a reminder, please make sure you're in a quiet room with your TV turned down all the way so we can hear your questions and you can hear Dr. Burke's answers. The number is 318-219-4569, and you'll see it throughout the show at the bottom of your screen. Dr. Burke, thank you so much for being here. We really appreciate it, and I wanted to talk to you all the way through the break until today, so I'm fascinated because you and I have talked about how we on Healthline 3 discuss robotic surgery every now and then, and we find out about it, and but you have really brought some fascinating stories today that I hopefully we can go through, if you don't mind repeating, because I've just been in awe during our breaks. But at first, let's go ahead and review again about what it's like for people who aren't quite familiar maybe with what robotic surgery really is, so just explain it for us.
Well, it's operating at a console using the robot as a tool or an instrument like a scalpel or a hemostat. We do not stand at the patient. We are still in the room and sitting at a console, and then we manipulate or move the robotic arms. The robot is not an autonomous machine that functions on its own. You have to have somebody actually moving those instruments, and that's where our job comes in to try and do that. So you can sit at the instrument, your arms are on a console so that they're steady, so it takes out a lot of the physiologic tremor that a lot of people have naturally. It is minimally invasive. With the laparoscope, we've transitioned from open surgery to laparoscopic surgery to now using the robot, and each step has given us more precision and allowed us to operate through smaller incisions, which benefits the patient for not having large incisions. So a gallbladder, for instance, it used to be 5 to 7 days in the hospital to have your gallbladder out. Now it's day surgery. You come in, have it out, and go home the same day. Some people go back to work the next day, depending on what kind of job you have now. And you operate through little incisions that are about 5 millimeters, which is roughly about an inch with that, and you use 3 to 4. On some bigger operations, you may have 5 little incisions, but it has allowed us to do it without the big midline incision, so there's less blood loss, less tissue trauma, and the patients heal much faster, less postoperative discomfort, and less time off of work with that.
That really sets the stage for really all the progression that's happened, because you think about, you have gallbladder surgery back in the day when it was an open surgery, and then say 5 to 7 days maybe, depending on the patient, recovery time. And so we always think it's the gallbladder that takes that long to heal, but it probably is it just all the trauma that goes through the body that you have to do to open up?
It was more so the incision than the actual removal of the gallbladder with that.
Because you're going through the abdominal wall, there's a lot that happens to the body before you even get to what you're trying to fix.
There's a lot, and long term with a lot of the open surgeries, of course, you go in, you make an incision, you're inside the abdominal cavity, well, you create a certain amount of scarring after that. And then people intermittently would come back with bowel obstruction from scarring. Now that amount has markedly decreased because you just don't get the scarring that you used to.
That's another thing, right, that is so interesting about scarring. I mean, that we have, as you know, from the patient side of you, have learned so much about scarring, how harmful scarring is in your body.
Scar tissue gives us a lot of trouble.
Yes.
They are luckily coming out with new technology and new things we can put on the inside when we have to do things open to hopefully decrease the amount of scarring long term, to prevent the bowel adhesions and try to prevent the hernias that can occur from the big long incisions that you don't really have as much a problem with the laparoscope, because those incisions are so small with that.
And you hear scarring more in one person than another. Does it also depend on the person's body too?
It also depends on the person. There's maybe some genetic link with it, we don't know, but some people just tend to scar down more than others. There are some people who may have had an open appendix 20 years ago, and you have to go in for something else and their abdomen's completely scarred down. Others may have had a big open colon operation 20 years ago, and you have to operate on them to take a gallbladder out. And you look in with the laparoscope, and for some reason they don't have any scarring at all.
Right. And so from a surgeon's point of view, when you you experience or you observe scarring once you're in there, what is that like? Is it hard tissue? Can you get through it? What does it do? What does it feel like?
Sometimes the tissue is harder than others, but what it does, the bowel and abdominal wall fuses together, so you can't separate it to get into the space and get where you need to be. It becomes very difficult. You can spend hours with a combination of scissors and a scalpel blade trying to get into lice adhesions for people who have bowel obstructions.
So that's got to be one of the biggest benefits right there from the surgeon side and the patient.
Long term, that is a very big benefit for the patient.
Yeah.
With that.
And so when we started just using the straight sticks, laparoscopy, like
Yes.
you were telling me, I'm learning all my medical terms here, so I'm like a doctor. So when you're doing the laparoscopy, that was probably just amazing that you only had those 2 incisions, which eliminated so much risk of scarring.
Tremendously reduced the scarring, and because if you go back to the laparoscopic, we have to thank our OBGYN colleagues, because they
Yes.
initially started doing tubal ligations that way, and then from there it progressed to where it is today.
I can
with that.
imagine the OBGYN field and patients, women, realizing they could have a tubal with laparoscopy. I mean,
Yes.
that's incredible.
And now it's progressed to, you have multiple different disciplines using it. OBGYN doctors, they are just terrific now about doing hysterectomies and other things and other much more complicated operations for cancers with the robot now that we used to not be able to do, which benefits the patient there. The urologist are doing urologic procedures, doing things to kidneys with the laparoscope, where you used to have a big flank incision to do that.
Right.
And it's just progressed to the point that the benefit to the patient has been just fantastic.
Phenomenal,
with that.
yeah.
But it's a multidiscipline thing. You have to have the support of the hospital, then you have to get the training for the surgeons, and then the support in your hospital, because I think the robots are well over $1 million with that. So, and I think we have 9 of them at Willis Knighton. And you think the capital outlay that the hospital has to go through to try and keep up with that technology, and the whole thing with the CEOs that we've had have been fantastic. Of course, I think everyone knows Mr. Elrod, and now Mr. Fielder's there, and they have been terrific about getting us the equipment that we need, because they have the long-term vision of what we need as we progress to bring that type of technology to the people of this area, which is a significant capital outlay.
Incredible to get to talk to you and hear about and let our viewers and everyone know what we have available right here.
Well, what we have in the expertise that you really have in Shreveport,
yes,
that a lot of people don't realize with that.
That people come to Shreveport from far away now, where we used to not want to have to go to Dallas or Houston or somewhere like that. Now people are traveling even farther than that to come to Shreveport for a lot of this care.
For some things,
it's really
correct.
incredible. So, okay, so let's go back to laying out the room. It's not just like you know all about this, and you have doctors are always training and learning more. There's so much maintenance on the robots themselves. We talked about that. Not only that, but Willis Knighton pays attention to taking care of them. It's proactive maintenance on all of these machines.
Yes.
So they're always top-notch advancements and maintained at the highest.
They're always, and as they get technology increases, and you have to update what you have, and they've been very, very good doing that.
All right. Well, we have a caller for you.
Okay.
Hi, John. Thank you for calling. What's your question for Dr. Burke?
Dr. Burke, I just had robotic surgery on my heart.
On your heart?
As
Okay.
of right, yes, sir. I had a single bypass on my LAD. When do you think where they can go farther than doing a single bypass with the robot?
Well, I don't do the cardiac surgery, so that's a little difficult for me to say, but what's slowly progressing as people get more experience with it, they're doing more and more with the heart surgery. And I think they will get to the point where, I know they're doing single vessels now, and they'll get to the point where they'll be able to do multi-vessels. And it's just that progression.
I had it.
You had it where?
My LAD was done, yeah.
Your LAD, yes. And that makes
and
it.
So it's a difficult surgery still with a robot, but your downtime is less, and that's what makes it so great to have the robotic type surgery now, because now you're, instead of laying 8, 6, 7 weeks off, now you're laying 1 or 2 weeks off, depending on what type of work you do.
That's true. A lot of it depends on your job with that. If you're a construction worker, you may be out longer than, say, you're an accountant, where you can go in and sit at a desk every day. So that does vary.
Correct.
But with the robot, you still have, as you said, your less downtime, less postoperative discomfort than having the incisions the way they used to do it, splitting your sternum with that.
Yeah, I have 3 incisions, you know, and I was off for 7 weeks because of the type of job that I've done. But I recommend this to anyone that who can have that done. I recommend a robotic surgery.
It is, and it is a good thing to do. And I know the cardiothoracic surgeries are jumping into this with both feet and trying to get as much experience as they can to keep pushing the envelope and doing more and more, to the point of doing valves and other more sophisticated heart surgeries this way.
Do you think that the institutions will be getting more, like the institution I was at, they had one robot that they had to share. I don't know how many you have at your institution. I was at a different one. But they have one that they have to share with the urologist and everyone else.
Yeah.
Do you see institutions now growing, probably trying to get more than one at each institution?
Yes, they all of them do. I think we have at least 2 at each hospital with that. I think we have 9 total, and they're trying to get another one. Some of the problems that they have had with the robotic surgery is access to a robot. There are a lot of people who want to try and get to that and start performing more robotic surgery, but don't have a robot, or the robots that are at the hospitals are now in such demand that it's hard to get to them at times.
Yeah, that is a problem, but that's why I was asking, do you see more probably coming to the institutions? Because the waiting line now that everyone wants to use a robot, it's getting extremely long.
That's true, and as the volume increases, the hospitals will put out the capital outlay to get more robots.
Well, I recommend this for anyone who could have it. I had it done. It's a tremendous surgery. The downtime is not hard. Basically, I could do anything I basically wanted to do. If I had a desk job, I was in the hospital 2 weeks, 1 week off at the house just to make sure everything was right. When I got the okay, if I had a desk job, I would have been back to work within 2 weeks.
Well, that's good.
Yeah,
I'm glad
I
you
recommend this to anybody.
did well and have a good testimonial of how important that robot is today.
Yes, sir. Well, thank you for your time, and I appreciate y'all so much. Y'all have a great day.
All right, thank you for calling.
Yeah, thank you so
Yeah,
much,
thank you.
John. We're really
All right.
happy the robot was available for John and he was able to have such a good experience.
Yes.
Yeah, that's really good point, though. Oh, we have another call for you. Hi, Gloria. What is your question for Dr. Burke?
It is that I am a diabetic, and medication is managing the diabetes. But however, I've been seeing
I
like
can't
double
quite hear you.
of everything.
It-
What you say?
We can't understand your question, Gloria.
It's a little bit hard to hear you,
Yeah.
Gloria. That's better.
Is that better?
Okay. I am a diabetic, but of course, medication is managing it. And I'd like to know when you start seeing double people, when you're looking at things. What causes that?
It's a little bit hard to understand what you're saying. You said you were diabetic,
Right.
and what's the question about the robot?
I've been seeing double.
You've been seeing double?
Yes.
Okay, and you're diabetic.
Right.
All right, that's your question of why are you seeing double?
Right.
Okay. Well,
Do you have a question about robotic surgery, Gloria? Has someone mentioned that to you?
No, no one has mentioned that to me.
Sometimes people who are diabetic have problems with their retina or retinopathy from the diabetes, which it can affect. So one of the things you probably would need to do to get a little more information, and somebody who knows a lot more about it than I do, would be to see an ophthalmologist or one of the eye doctors so that they can perform a good eye exam and look and then come up with suggestions on how to help treat that.
Okay. All right. Thank you so much.
Yes, ma'am.
Thank you for calling, Gloria. And so that's another good point. We talked about both of these are really good to bring up because we need to talk about the different things that robotic surgery do. Like, what are the surgeries you mostly do with robotic?
Well, as a general surgeon, we do a wide variety of abdominal operations. We do the gallbladders or the cholecystectomies, the inguinal hernias, incisional hernias. We can remove the bowel, colons, the appendix is that way. We do anti-reflux surgery for people who have reflux disease or bad heartburn. There are several different operations to go in and help with the reflux. And also hernias in the diaphragm, what are called hiatal hernias, are now all repaired that way. We've taken out spleens and other things that need to be done, that you no longer need the bigger incisions. The problem you sometimes had with the spleen is you have it all dissected free with the robot and the tiny incisions, but the spleen is much larger, so how do you get it out?
That was my question. I don't know if I could ask that. We have these little incisions, but how do they get out of the body?
You can put it in a bag and kind of morselize it or break it down to take it out that way.
Wow.
With that.
That's incredible, because that was my visualize. Okay, it sounds all this surgery is great, but how do you
And
do
believe it or not, sometimes that is what gives you the largest incision for a laparoscopic procedure. You've taken a right colon out, a left colon, a sigmoid colon, you have them all hooked back up and you have to get the specimen out.
You're right.
And sometimes in order to get it out, you have to extend one of those little port sites to get it out. So that's essentially what gives you your bigger incision.
That's remarkable. It's still not as big a incision as having to go in and open someone.
Still not as big as, correct.
Yeah. And I never thought about that too. You're blowing the abdomen up with gas so that you can see what's going on in there. And then, like when you mentioned how you have to be careful, I never thought about when you make the incision, does the gas escape? How does it not escape the body?
Well, the ports are kind of cylindrical tubes that we use, and you make a little incision in the abdominal wall, then you work it through the abdominal wall, through the muscle, and into the abdominal cavity. Once you have them what they call insufflated, or you have their stomach blown up, it's the best way to say it looks like you're 9 months pregnant.
Yeah.
Because we blow that up to have a cavity inside to be able to work in, because if you don't have that space, then you can't get the instruments in and don't have enough room to work, which occasionally can be a problem. But once you're in there, the instruments have the port sites have little diaphragms in them, so you put the instruments through it and then it won't leak air around it. And that was one of the problems with the laparoscope, that moving the instrument in and out of that diaphragm, you would have a drag on it. So it made it a little bit more difficult to move it to 2 to 3 millimeters that you needed to in order to work. Now with the robot, it takes all that drag out for you don't have it anymore.
Okay. I'm getting all my questions
So the
answered.
precision is much better and the range of motion is much smoother, more precise.
That's incredible. Okay, we have another caller for you. Tasha, thank you for calling. What is your question for Dr. Burke?
Hello, how are y'all today?
We're doing fine.
Good. I got in on the last part of this, so I'm not sure exactly what y'all were talking about in the beginning, but my eyes have gotten really, really bad. My age is 49 years old. And I'm currently using some reading glasses, and they do help. But at my age, do I need to go to an optometrist to get prescription glasses, or are the reading glasses sufficient for me? I mean, what steps do I need to take? I mean, my eyesight has gotten completely, real horrible.
The reading glasses that you have, when you went to the store to buy them, it has a number on them. It has a plus 1.5 or a plus 2.5 or a minus. Which ones did you get?
I started out with the 1.50s, and then I went up to the 2s. Plus.
Okay. So now you started off at the 1.5, and now where are you?
Sir?
You started off, you said you got the 1.5. Have you gone up to the 2 or the 2.5s?
2.5, yes, sir.
Yeah, I think it's starting to progress a little bit. How long ago did you get your first pair of glasses?
I said my eyes started to bother me around 44 years old, and now I'm 49, somewhere in my early 40s.
Okay, so you slowly had a progression over those past few years. Well, it's always good to go see either the optometrist or the eye doctor so that they can give you a good eye exam and make sure they measure the eye pressures to make sure you don't have any progression of glaucoma or anything else. So I think it would be good
Yes, sir.
to see. There's several good ones in town. There's some really good eye doctors here. So I think it's you'll be real lucky. Just probably anyone you choose would be excellent.
Right. I know that I had taken my granddaughter to the optometrist, and I was with her when they did all the tests and everything, and they were explaining stuff they were doing to her. So I kind of know what you're talking about the pressure and everything. So that's what I'll do, is just make me an appointment. I was just making sure I wasn't like that was okay that I just used the reading glasses, or was that completely normal at my age? I guess
the reading glasses are okay, and as we age, like our whole bodies change, our eyes and
my mom
everything
said
else.
that
We
she
wish it
started
didn't.
seeing differences. Right, I know.
And you just had a slow progression, which is what happens to people, but I think it's always good to...
It's gotten real worse real fast in about the last 6 months.
Yeah,
but that's what I'm concerned about. I can't even see my phone at all without putting them on.
To let the eye doctors examine you to make sure everything's okay, and then they may need to adjust that and give you a little better prescription, and then sometimes, they may have to decide if you need bifocals.
Right. When I take them off, I'm able to see the TV again. I can't drive with them on. I can't see to drive with them on. But as far as reading things, like a newspaper or small print on my phone to text, I have to have them on.
So you can see far away pretty good. It's just things up close, it gets blurry. Is that correct?
Yes, sir. That's correct.
Yeah, I think I would go see them, and they can probably get a good pair of glasses for you and correct all that.
Okay. All right. Well, thank you so much for your help. That was something I was needing to ask somebody, and you'd be the one to ask.
All right. You're welcome.
Okay. Thank you. You have a good day. Bye-bye.
Thank you so much for calling, and thank you for that answer and for taking good care of her. Appreciate that. And we should remind everybody we're talking about robotic surgery today. And Elva, we have an Elva on the line. What is your question for Dr. Burke, Elva?
Yes, I just got an eye exam 2 months ago, and I have to take my glasses off to read up close. And I was when I went and got my glasses, the lady said they don't have bifocals. Why don't the doctor know to give bifocal? You have to tell them?
No, ma'am. Most of the time when they go in, and as I said, I'm not an ophthalmologist, but when they check your eyes, they would check for both. So you can see up close, but you can't see far away.
I can't see far away. That's why I wear glasses.
Okay, you can't see far away, but up close is okay. You can see up close. To read a newspaper, you can do that.
I can see up close without glasses, but I have to take my glasses off. And these are prescription glasses. I've been to a doctor to get these glasses.
How long have you had the glasses?
I've been wearing glasses since I was in 3rd grade.
Okay, but this last pair, how long have you had this last pair?
I've been having this last pair for about 4 months now. I got them in March, I believe. March.
Well, I think I would go back to your ophthalmologist and explain to them what's going on, and they could adjust those, and if they thought they needed bifocals, then they would hopefully get you those. But it sounds like if you can read up close that you might not need the bifocals, it's just the distance you're having trouble with.
Okay, shouldn't they have detected this during my eye exam?
Well, they would have, and it depends on what kind of questions and what you told them. As I said, I'm not an ophthalmologist, so I can't tell you for sure what questions they would ask you.
Okay. All right, then. Thank you.
Yes, ma'am.
Hi. Thank you so much for calling, and thank you for being so wonderful and talking to everyone about their questions. We just want to remind everybody that we won't be able to take any other calls today unless it's about robotic surgery and the topic that we're talking about with Dr. Burke today, although you've been very kind and patient. And we really love anybody calling about anything. But today we need to just wrap it up and still talk about robotic surgery. And so we're talking about that. Set the room up for us. We talked about how it's the robot and you and your training, but there's also a team that is they are specifically trained for this too. In the room, there's a lot of people there working with the patient while you're with the robot, right?
That's correct. It's definitely a team approach with that. You have the anesthesia doctors who are putting you to sleep and taking care of you while you're asleep. You have the scrub techs and the nurses which are in the room. And then now we have what's called a bedside assistant, which is nowadays either a certified surgical assistant, someone who has to go back to get extra training in order to do the robot, or it's a PA or a nurse practitioner, which scrub in to help. So we have that added expertise at the bedside who are scrubbed in to help change the instruments when we need to change the instruments on the robotic arms, to get different graspers or scissors or different energy sources and used in order to control bleeding and other things. And then they also assist by manipulating the bowel with other graspers to help us get retraction. So they're a higher level of expertise than just a scrub tech would be. So they had to go back and get extra training and then go through a course with the robot in order to be able to use it.
Which is really comforting to know too, that you're surrounded with a team who specifically is trained to this particular subject.
And everybody's well trained, and then a lot of them have a lot of extra training because of the robot being a relatively new instrument, I guess, with that. It's been out for several years now, but and even the robotic company wants you to be trained in order to do that. So they have special training classes that we can send them to do that.
Right. So you're just surrounded by all kinds of, and plus since it is relatively new, like you said, you've got probably years and years of training possibly with the people who are at the table who've just been doing it other ways and have grown and learned. I mean, they could be new and came right into robotic.
A lot of them have progressed as we have.
Yeah.
From open
a lot
to
of knowledge.
The laparoscopic and now to the robotic surgery with that. So they've seen the progression, and you can see the benefits of it.
The benefits for sure on both sides. And so what was the gap? Was robotic surgery being thought of and worked on while laparoscopy was being used too, or how did all that advance?
It started, if you want to go back to really the hypothesis of the robotic surgery, really came out of the military, trying to see if they could get a higher level of care closer to the front for injured soldiers with that. So, and that started back in about 1967, the hypothesis of trying to do this. But the actual technology didn't really start till the late 90s, when you started getting the high-speed computers, the microprocessors, and other things that you needed for that technology. Then it slowly started progressing from there, and I think the first actual robot was something called a Hermes, where you actually just moved the camera, and you still was kind of a hybrid between a laparoscope and the robot. By now you had a voice control on the camera where you can move the camera. Then they had one called a Zeus. Now they have the Da Vinci, which is the latest one with that. But the first, I think, gallbladder removal was actually in Brussels, Belgium in 1997 or so. And they tried to write it up as a publication, and I think the New England Journal of Medicine and the Lancet, which is the British journal, both of them refused to take it at that time.
Interesting.
So then, roughly a year later, I think they did the first purely robotic one, and it was actually a bariatric surgery that was done with that.
So this is the thought of it way back, and it's been progressing all the time. So we're really happy to have it here now. So
And then
thank you.
part of it is the laparoscope was progressing. That was helping the robot because you were developing better instruments and people were getting more experience of the minimally invasive surgery. So then they started kind of meshing and progressing together.
Fascinating. Well, thank you so much.
Okay.
It's been such
All
a
right.
pleasure. And thank you for watching Healthline 3. We'll see you next time. Enjoy
right.
your afternoon.